Pericardial effusion and the X-ray is the clinical topic of discussion for today. Before going into the imaging, few important points related to the pericardium. It is nothing but a serous sac which is covering the heart. Two-layered, many pathologies can occur. To be more particular, pericarditis, inflammation of the pericardium is pericarditis. It can be acute or chronic. Fluid collection in the pericardium is pericardial effusion, again can be acute and chronic. Cardiac tamponade, more amount of fluid causing some issue to the heart, cardiac tamponade, constrictive pericarditis, and very rarely pericardial mass. These are all the problems in summary. Coming to the effusion, normally how much amount of fluid is there in the pericardium? On an average 25 ml to 40 ml. Normally for the normal functioning of this heart movement, and the covering should move freely. For the particular function 25 ml to 40 ml might be there. Coming to the pericardial effusion. This pericardial effusion, the symptoms and the amount might not match. Why? The pericardial effusion symptoms depends on the rapidity of development and most likely other etiology also, why the patient developed. Because a rapidly developing effusion can give a severe symptom at a lower amount of fluid in that particular area than a slowly developing one. So what are the investigation which are available to find this particular thing? Chest X-ray, 2D echo, CT and MRI. In the ward, most likely we will be encountering chest X-ray followed by the echo. CT per se for pericardial effusion evaluation might, compared to X-ray and echo, is somewhat less common. Chest X-ray is the most common investigation we usually come across. Coming to the mild, moderate and severe category. As in ascites, as in pleural effusion, and pericardial effusion also mild, moderate, severe can be there. So amount wise, what is that? As I already told, on an average 25 ml is the normal fluid. So to say as massive or large pericardial effusion, the fluid have to be on an average more than 500. 250 to 500 we can say it as moderate, less than 250 can be a mild effusion. It is just for theoretical purpose. Wait, the main discussion during the imaging we will do. So value wise, normal is 25 ml to 40 ml, can take 50 ml also up to 250, mild be mild, 250 to 500 moderate, more than 500 we can say as a larger one. But this value at this point, as a resident, you should understand a patient might not be built at the same level. The patient build is different, gender varying. So this absolute value of the fluid might not be a good parameter to describe the effusion. And one more thing, it is very difficult to find how much the fluid is exactly there. So this probably an MCQ part of discussion, a theoretical outline regarding the fluid. That is why the absolute value you might not find in the text also, because the patient are of different sizes. Coming to the chest X-ray first. In the chest X-ray, mild effusion you might not able to see any finding. Okay, in the chest X-ray. When you are seeing a large globular shaped appearance, probably in the background we are keeping the X-ray, water bag or money bag appearance. It is look like a water bag which previously around centuries back they used for as a water bottle. That particular appearance, if you get, most likely it will be a large or massive pleural effusion. Massive, a large amount is there in the pericardial space. That is why these findings are there. Globular heart, cardiothoracic ratio is very much widened. That particular outline of the heart you might not find, that left atrium, aorta, those finding might not be there. The entire heart might be somewhat globular, as you are seeing in the X-ray right now. The lower part might widened, and the angle between the cardiac shadow and the diaphragm might be more acute. These are some theoretical description. But if you find a globular heart, or by means we can say money bag appearance or water bag appearance, that is large category. Whereas in moderate, probably a cardiac silhouette might be somewhat bigger, cardiothoracic ratio might be bigger. So in the X-ray, mild, you might not find any finding. Massive, these kind of large globular, the typical water bag appearance might be there. Moderate, the globular heart, probably this kind of typical appearance might not be there. We're keeping another X-ray, you can have a look. This kind of some kind of cardiomegaly type of picture you might find with respect to X-ray. Coming to the echo now, 2D echocardiography. Okay, in the echo. In the echo, heart is there, pericardium is there. The separation part, that is what we are going to use to find mild, moderate and severe. This heart is there, you are able to make out in the echo. In the background we will try to put an image. The pericardium, the space in between, it will be very black. When the heart is normally contracting, relaxing, contracting, relaxing, contract systole, relaxing diastole. So in the end diastole time, the distance between these two probably will serve as a marker for mild, moderate and severe. If it is less than 10 mm, mild, 10 to 20 mm, moderate effusion, more than 20 mm, probably a large effusion. Even the heart and the pericardium, that gap, outer layer, gap, will be dark in color. Technically, end diastolic time nothing, but heart is relaxed so that you are able to see. Whereas if the heart itself is constricted because of the fluid, we will call it as cardiac tamponade. That is a very severe form of it. So in the echo, probably at least clinically a semi-quantitative. In this also you can't exactly tell how much it is there, but we can make out less than 10 mm mild, 10 to 20 mm moderate, more than 20 mm is massive or large pericardial effusion. Okay, then any other modalities are there. CT and MRI is there. If the pericardial thickness or pericardial space, if it is more than 4 mm, that is a criteria that can be used for your MCQ also, or for clinically interpreting image also, which will be better seen in the console itself, or the radiologist will give the report. If it is 4 mm and more, it is pericardial effusion. At this point of time, one information is echo is the most common modality we will use to manage the condition. Why we want to know mild, moderate and severe? Because we have to manage it. A particular terminology, for example, moderate effusion, mild effusion doesn't make the difference unless we are treating it. So that is why semi-quantitative, approximately we are knowing, that is more than enough. To follow it up or to see the response, that is more than enough. Okay. Echo, semi-quantitative, that is more than enough, because mild, moderate, large, the demarcation is to tell the clinical severity. Larger the effusion, higher the chances of converting into cardiac tamponade. It is a terminology, nothing but the fluid is so much compressed, it is start pressing on the heart. The heart is going for some kind of dysfunction. That's it, at least as a summary. So if we find this kind of mild, moderate, we have to treat the etiology. Large, probably a pericardiocentesis. It's nothing but removing the fluid from the pericardium. That might be required. So in summary, X-ray, moderate and severe easy to make out, mild you can't make out. Echo is the investigation. Preferably you can do to semi-quantitatively assess to say mild, moderate and severe. And the treatment, pericardiocentesis in severe to avoid the cardiac tamponade. And to start with, you have to know the etiology, because the discussion is pertaining only to the X-ray and the pericardial effusion. To conclude that, you should know the etiology. Commonly, what are the things we will encounter in India? Tuberculosis, uremia, malignancy. Medical ward. Surgical side, probably a traumatic one. Apart from these three, any other causes are there? Yes, more common these three. Below that comes the drugs, autoimmune diseases comes. Apart from this, unlikely any other etiology you are going to encounter in your first year or second year residency. Always TB, CKD, uremia part of volume overload, drugs, malignancy part of autoimmune disease. Nephrotic also comes under the part of any kind of autoimmune or albumin is low. I hope the resident who are saying in this, at least till this time, you are in a position to understand nephrotic. If I mean, you are able to understand oncotic pressure is not there, which is part of a syndrome of CKD, or probably a nephrotic itself can be a common one as a part of a spectrum. Isolated pericardial effusion is rare in nephrotic. The patient will be having in pleural and ascites also. So isolated pericardial effusion, always look for TB, malignancy and uremia drugs. So that's all for today. Bye bye. We'll see you in the next video.